Hello everyone, my name is Quy Tran and today we're going to talk about the basics of immunotherapy for palliative care providers as presented by a palliative oncologist. First, some disclaimers. Number one, these slides will not teach you to become an oncologist. Number two, these slides were meant to give you an appreciation and basic understanding of immunotherapy. And number three, please note that media and other work products used in this educational presentation are copyrighted by their respective owners. Use in this presentation is for nonprofit educational use in a teaching scenario. Distribution of this presentation for purposes other than education requires consent from the respective copyright holders. Some disclosure information. Number one, no relevant financial relationships to disclose. Number two, no honoraria were accepted for this presentation. And number three, all opinions are my own. So before we start, just a little history. Immunotherapy could probably be traced back to China's Qin dynasty around the 3rd century BC, where there are some scant reports of purposeful inoculation with variola minor virus in order to prevent smallpox. But it wasn't until the 1790s that Edward Jenner demonstrated protective immunity against smallpox through purposeful inoculation with common cowpox virus, which many consider the start of the vaccination era. But we're not here to talk about vaccines, we're here to talk about using the immune system in the fight against cancer. Although reports of cancer immunotherapy can be traced back to ancient Egypt, it wasn't until William Bradley Coley in the late 1800s who actually deliberately tried to manipulate the immune system to treat cancer. After observing cases of spontaneous cancer remission after patients had erysipelas, he deliberately injected Streptococcus and Serratia as the first immune-based treatment for cancer. He even reported over 1,000 cancer regressions with this treatment. Now, injecting pathogenic bacteria into cancer patients has its downsides too, so his success never actually took off. Interest in the immune system picked up again in 1945 with the discovery of interferon. You then start to see more documented successes in the 1970s with BCG in melanoma and bladder cancer. BCG is still used today by urologists to treat non-muscle invasive bladder cancer by activating macrophages against the tumor. And steady advances have continued on until this present day. I am not a receptorologist, nor do I claim to be one, but let's take a look at the mechanism of action slide to understand some of the underpinnings of modern immunotherapy. Now, I recognize that this slide can give you headaches and is super busy, but it's not meant to confuse you. It is here to give you context on how our current understanding of immunotherapy works. As a palliative care provider, there are two things that you should understand. First, treatments can be thought of as those that directly target the tumor itself or indirectly at the environment in which the tumor resides. Most of you are familiar with treatments that target the tumor directly. These include chemotherapy, radiation, and many biologic therapies, and each have their role in cancer care. But immunotherapy is a little more complex. And the key to that complexity are lymphocytes, which are important in both identifying and eliminating cancerous cells. Lymphocytes are a part of the immune system and interact in both the microenvironment surrounding the tumor and with the tumor itself. We have come to understand the importance of a couple of key interactions, one of which is known as immune checkpoints. Their role is to prevent the immune response from being so strong that it destroys healthy cells. You can think of immune checkpoints as off signals for the immune system, and cancer cells can exploit these off signals to turn off and evade the immune system. Let's take a look at this. Normally, when a T cell encounters a cancer cell, it recognizes it and immediately eliminates it. Checkpoints such as PD-1, which turn off the immune system, can also be expressed by cancer cells, thereby allowing cancer cells to turn off the immune system. Immunotherapy, known as checkpoint inhibitors such as PD-1 or anti-PD-L1, block that interaction, switching the off signal back on, allowing the immune system to recognize and eliminate cancer cells. PD-1 and its ligand PD-L1 is just one target of checkpoint inhibitors. The other is CTLA-4, but the principles are similar. This is a list of currently approved immunotherapies so that you are just aware of different treatments as a palliative care provider. You can see the proliferation of drugs since these discoveries. Anti-CTLA-4 or ipilimumab, anti-PD-1 with nivolumab, cemiplimab, and pembrolizumab, anti-PD-L1 with atezolizumab, avelumab, and durvalumab, as well as CAR T therapies, cytokine infusions, vaccines, and viruses. Some palliative care key points. Number 1, the immune system interacts with the tumor and a microenvironment in which the tumor resides. Number 2, CTLA-4, PD-1, and PD-L1 are involved with checkpoints that help turn off the immune system. Number 3, checkpoint inhibitors or immunotherapy block the off switch of the immune system, thereby turning on the immune system, allowing lymphocytes to identify and eliminate cancer. Very few of you will be writing orders for immunotherapy, but as palliative care providers, immunotherapy-related adverse effects are an area where we can be helpful. This is a slide showing potential areas where you can get adverse effects. Take a look at the left side of the slide. Essentially, anywhere an itis can occur, that is a potential adverse effect. The eyes, lungs, liver, pancreas, skin, joints, bone marrow, GI tract, kidneys, heart, nervous system, and endocrine system. The two graphs on the right show when the most common side effects are likely to occur, typically within weeks to months, but they can happen almost any time. As a palliative care provider, the table on the bottom right is important to be familiar with. Diarrhea colitis is quite common, particularly with regimens containing ipilimumab, a CTLA-4 inhibitor, as a sole agent or in combination. Skin rashes are next, common with both ipilimumab and anti-PD-1 and anti-PD-L1 therapy. Pulmonary issues like cough and pneumonitis are common with anti-PD-1 and anti-PD-L1 therapy. Hepatic and renal issues are next, which is why we regularly check comprehensive metabolic panels. Endocrinopathies are next, which is why we check TSH and free T4 every other cycle, and make sure to screen for signs and symptoms of both hypothyroidism and hyperthyroidism. Then you have neurologic and cardiac issues. Once you're able to identify a side effect, you have to be able to grade it. Grading is like staging, as it helps both to prognosticate and to define treatment. In oncology, we use the Common Terminology Criteria for Adverse Events, or CTCAE, version 5.0. For grade 1 or mild, it is asymptomatic or with mild symptoms. Clinical or diagnostic observations only, and intervention is not indicated. For grade 2 or moderate, there is minimal, local, or non-invasive intervention indicated, and it is limiting age-appropriate IADLs. For grade 3 or severe or medically significant but not immediately life-threatening, hospitalization or prolongation of hospitalization is indicated. It is disabling, and there is limiting of self-care ADLs. For grade 4 or life-threatening consequences, urgent intervention is indicated. And for grade 5, it is death related to the adverse event. By identifying the side effect, then grading the severity of it, you can then define how best to address the side effect. This is a basic graph on how to approach immunotherapy-related side effects. For all grades, make sure you control what the symptom actually is. For grades 2 and above, there is a potential of stopping immunotherapy. And depending on what is going on, you can consider topical, oral, or intravenous steroids to reverse the side effect. Many times, high-dose steroids may be needed for grade 3 or 4 side effects to be started, then accompanied by a prolonged taper. Occasionally, you may have to refer to a specialist like a dermatologist or gastroenterologist, and rarely, you could potentially consider infliximab, a TNF-alpha inhibitor. As palliative care providers, we are very likely to encounter the two most common side effects, rash and diarrhea. In these tables are standard treatment for each grade of rash or diarrhea. For grade 1 or 2 rashes, use heavy moisturizing creams or ointments. You may consider antihistamines and topical steroids. For grade 3 rashes, you may add on a systemic steroid and hold the immune treatment. For grade 4 rashes, it may likely require referral to a dermatologist. For grade 1 or 2 diarrhea, use loperamide and make sure the patient is well hydrated. Pain or bloody stool may require an endoscopy referral. Topical mucosal steroids may be required. Grade 3 or 4 diarrhea may require hospitalization and systemic steroids and hold the immune treatment. Some palliative care key points. Number 1, an itis or inflammatory side effect can occur in any organ system, typically within weeks to months, but can occur at any time. Number 2, skin, such as rash or pruritus, and GI, such as diarrhea, issues are the most common side effects, but think of lung and thyroid issues. And number 3, grade side effects and choose appropriate interventions based on grade, control the symptom, and think of topical or systemic steroids if necessary. This slide is important to just note as a palliative care provider discussing risk and benefits of immunotherapy. Despite how great the benefit of immunotherapy is for many patients, there are side effects and even deaths that do occur with immunotherapy. Deaths are less than 2% in studies, but probably closer to 4% in real-life scenarios, but the risk is still real and should be communicated adequately to patients. The chart on the upper right is an interesting chart. It shows which symptoms due to immunotherapy-related adverse events that are most associated with fatality. For example, you can see that many people get colitis. It's a common side effect, but few patients die of it, whereas myocarditis is quite rare, but has a high fatality rate in the 40 to 50% range. The chart on the bottom right shows that if a fatality is to occur, what the median time to onset of symptoms were prior to the patient's death. This is a chart that I think many in the palliative care community struggle with. Prognostication is often an imprecise science, but decades ago, even with the use of chemotherapy or even targeted therapy, patients with advanced cancers eventually died of the cancer. Many palliative care providers were taught to prepare patients for that inevitability. Today, with the advent of immunotherapy, you're starting to see real and significant survivor curve tails indicating a proportion of patients who are long-term survivors of even very advanced cancers. And you need to keep this in mind when discussing the potential benefit of immunotherapy. This is a general chart, but typically we are seeing about a 20% long-term survival with ipilimumab alone. In fact, 20% of patients treated in the pre-2011 trial are still alive today with no evidence of disease. PD-1 therapy alone is slightly better than CTLA-4 inhibition with long-term survivals between 25 to 30%. The combination of ipilimumab and PD-1 inhibition in some cancer types is producing survivals approaching greater than 50%. And the hope is that as we continue to learn more about treating cancer patients, we can continue to push survival statistics higher and higher. Now, this is just not theoretical. You can actually see the real-world benefits of modern cancer treatments in disease states such as advanced melanoma. You can see the improvement in the Kaplan-Meier survival curves as we step through each generation of cancer treatments. we have essentially gone from dismal survival benefits using chemotherapy, as noted in the bottom left of the chart, the brown line, to amazing results with the combination of nivolumab and ipilimumab in the upper right of the chart, the dark green line. This presents a challenge to palliative care. How do you prognosticate, and how do you communicate that prognostication? Well, we deal with uncertainty all the time. Just look at how we approach dementia, stroke, COPD, CHF, liver disease, or even end-stage renal disease. The way I've started to approach this is just like any life-sustaining or destination treatment, like LVADs, dialysis, chronic ventilators, or maintenance transfusions. There will be long-term survivors, and that's okay. In fact, it's great. We also have the tools to help provide general prognostication should a patient require hospice or palliative care. And when the time comes, we are all well trained on the communication tools that are required to help with that transition. I think it's important to note that no matter the changes that occur with treatment or prognosis, the tools for effective communication are still applicable. This is the classic Lamont and Christakis paper published now almost 20 years ago that outlined 4 key steps in communicating a prognosis. I think it's worth just reminding us that these steps are as applicable 20 years ago as they are today. The 4 major steps are preparation, content, patient or family response, and close. Step 1, communicating prognoses, the preparation step. First, research the patient's condition to determine prognostic parameters with and without therapy, for example, life-prolonging and palliative. Next, arrange a meeting in a private place with ample time, seating, tissues, and no interruptions from phones, pagers, and staff. Alert the patient ahead of time that you need to discuss important aspects of his or her health. At the meeting, first establish how the patient is feeling, identifying symptoms that can be the later focus of discussion of palliative therapies. Establish the patient's understanding of his or her illness. Ask what the patient hopes you will be able to do. And finally, establish what the patient wishes to know from you about their illness. Step 2, communicating prognoses, the content step. First, tell the patient that you have good or bad news to share. State the news clearly, simply, and sensitively. Provide the information in small amounts at a time. Make optimistic statements that are truthful. And anchor the survival estimate you communicate in previously published data and modify it by the patient's current clinical status. Step 3, communicating prognoses, the response step. First, acknowledge the patient's affect and express empathy. Allow the patient to express any emotions and goals, and assure the patient of your continued involvement in his or her medical care. Step 4, communicating prognoses, the close step. First, summarize the news sensitively and outline a short-term plan of care. Arrange a follow-up visit, since it is a tangible example of continued commitment to the patient. Offer to discuss the news with people important to the patient who are not present. Provide the patient with the means of contacting you and your team in an emergency. Some palliative care key points. Number 1, treatment deaths can occur with immunotherapy, and it depends on which side effect happens. Number 2, immunotherapy has improved survival for many patients with advanced cancer, including some long-term survivors. And number 3, palliative care providers can assist with prognostic uncertainty with skilled communication to comfort those in which treatment has not worked and plan for survivorship in which treatment was successful. Many of us are familiar with the landmark TEMO study, which for the first time established definitively that early palliative care, when coupled with chemotherapy, patients not only had improved quality of life, They also had an increase in overall survival. This study set the standard on how we deliver palliative care concurrently with cancer care. However, that study was in the era before immunotherapy, and immunotherapy today not only has a different side effect profile, it also has a different prognostic outlook. Whether early palliative care concepts can extend to immunotherapy is yet to be seen, but there are a few things that as palliative care providers you should keep in mind. Take a look at panel A of this slide. In theory, palliative care can be synergistic with immunotherapy by decreasing stress, elevating mood, increasing physical activity, and implementing best supportive care. Patients may potentially get the benefit from the combination of palliative care and immunotherapy. But the interaction is probably much more complex. Take a look at panel B of this slide. A number of inputs can produce either or both stimulatory and inhibitory effects. Just take a look at the variability of physical activity. As palliative care providers, we need to take into account two of our most used drugs, opioids and steroids. Palliative care uses a lot of opioids, but opioids have proven immunosuppressive effects, which are complex and multidirectional. In fact, the effect of opioids on the immune system is profound enough that several early studies have shown that chronic opioid usage in patients receiving immunotherapy have lower response rates, worse progression-free survival, and lower overall survival. The effect is greatest with morphine and fentanyl, less with oxycodone and tramadol, and the weakest effect is with buprenorphine. So whereas in the past, many of us were trained to be very aggressive with opioids for metastatic malignant pain, I do believe that we need to rethink the risk-benefit equation and whether we may potentially jeopardize or hinder the benefit of immunotherapy. For me, I still use opioids as the mainstay of malignant pain, but my titrations are not as aggressive if my goal is to optimize immune therapy. Steroids are also a common drug we use. Almost 50% of palliative care patients are on them at some point. In immunotherapy trials, most patients on 10 milligrams of prednisone or more were excluded, which means we don't know what the benefit or risk may be for patients using both steroids and immune therapy. Some small studies show that use of steroids above 10 milligrams of prednisone daily was associated with lower response rates, progression-free survival, and overall survival. Since we use steroids typically with patients with lower performance status and thus heavier symptom burden, or in patients with complications like brain metastases, it may simply be a marker of poor prognosis rather than directly affecting immune therapy itself. But until we know for sure, it is recommended as steroids being used prudently when specifically indicated. I would like to bring up a final thought around the concept of survivorship. In the past, cancer treatments were continued until it was too toxic or until there was evidence of progressive disease. In either case, we would typically be managing a transition to end-of-life care. But in the era of immunotherapy, the concept of survivorship and the intersection of survivorship with palliative care opens up a rich area of potential collaboration in clinical care. As a palliative oncologist, although I have had the honor and privilege of guiding patients as they close the last chapters of their lives, I'm also starting to see and care for patients who now have the ability to write new chapters of their lives, and at least for me, this brings about an exciting new era. As palliative care providers, we can and should start considering how we manage survivorship. A complete talk about survivorship planning is another topic, but here are some thoughts to consider. Number one, duration of immunotherapy is not optimally defined. With non-small cell lung cancer, some studies suggest that 2 years may be enough to obtain benefit while balancing costs and toxicity of treatment. As palliative care providers, we need to manage the anxiety and fears associated with stopping effective treatment. With regards to long-term side effects of immunotherapy, about half, or 40 to 50%, will have a chronic side effect. Of those, most, around 96%, are mild. Some, around 4%, are severe side effects. And some chronic side effects include rash, thyroid issues, joint pain or arthritis, conjunctivitis or blurry vision, and pituitary issues. Consider creating a survivorship plan for long-term survivors. Some tenets of a survivorship plan include treatment summary, a surveillance plan, a prevention plan, an intervention plan, and coordination of clinical teams. Some palliative care key points. Number 1, weigh risks and benefits of opioids and steroids in patients receiving immunotherapy. And number 2, consider creating survivorship plans in patients who are long-term survivors. Thank you for allowing me to present today. Do you have any questions or comments that I can help address? And feel free to email me if you have any further questions.